Okay, we will start this session because the difference between the previous session and this session is that here we will be focusing, as in the previous session I was, very forcefully commenting about and we had a lot of argument about the drying effect, because even with these newer agents available, there's no comparison or maximal drying effect is today with Brolucizumab. I am just waiting for comparative trial between Brolucizumab and steroid, or Brolucizumab versus Faricimab, for better understanding of our disease as a real world scenario in case somebody can do. So this session is primarily, we'll be diving deep into Brolucizumab because there are a lot of myths and realities surrounding Brolucizumab. In fact, in the last session and one or two sessions before this also, people have that myth, people have that fear of IOI. And that is the reason I think they use it less. But I think all of you are aware, Anirudh, also, that the data which we have from Indian subcontinent, I think so many injections have been given, lakhs and lakhs of injections have been given. I'm not saying it's zero, but it's not 4%. It's not 4% at all. Maybe it's 0.4%. So I keep joking with the, Novartis people that some point has been missing from somewhere. Instead of before, it has been put after. Because that is my personal, because I have used it more than 118 eyes as of today. And one patient who is 82-year-old gentleman, we have used it in a single eye, left eye, 30 injections we have given till today. 30 injections, not even a single IOI. So with this, I think we will move on to request Anirudh to log on and speak on bridging the unmet need in DME. Yes, Anirudh, we can see your slides.
Good afternoon, everyone. So first of all, thank you very much to Lalit Verma sir, to the entire leadership of AIOS and Novartis for organizing this session. Like sir mentioned, we will be diving deep into Brolucizumab and addressing the unmet need in diabetic macular edema. So in general, these are the contents that I will be talking about in brief: the disease burden, the unmet need from the perspective of the patient, physicians, and the healthcare system, summarizing the clinical trials, and then I'll show you some real-world cases. So we know that diabetic macular edema is a significant problem all over the world, in the Middle East, also in India now, and the projections are that we have millions and millions, 74.2 million people already affected by diabetes, and this is going to only exponentially increase. And we have significant number of people already with diabetic retinopathy in this population, and this is to the tune of more than 15 to 20%. So if you look at patients with
Anirudh,
DME,
one sec, wait.
Yes.
Achha, they had seen. Okay. Yeah, carry on. We are not seeing. They are seeing. Carry on.
Thank you. So if you look at the problem from three perspectives, and I'll be talking to you briefly about all of them: patient's perspective, physician, and healthcare perspective. I'll tell you how challenging it is and why we need molecules such as Brolucizumab to address this problem. So of course, if you look at the patient's perspective, the patient have multiple comorbidities. They have to not only look at their retinopathy, neuropathy, nephropathy, and other diseases. And so this not only adds to their treatment burden, and so we look for an agent which is long lasting and is very effective anatomically. Patients with DME have poor quality of life due to various reasons, and this includes not only the eyes but in general the dependency and lack of social functioning that they can do. And of course, because they need multiple clinic visits, it takes away time off from work for the injections. Now in general, in India and Europe as well as US, we see that the compliance for DME treatment is quite low. If you look at the Indian data, 50% patients are non-compliant with repeated injections. And I was hearing from the previous session talking about protocol S, and really if you have to follow such protocols, it becomes extremely difficult in a country like India, where you have to do multiple injections periodically without a specific deadline to this. So, of course, there are long waiting times, there are other medical conditions, and this leads to loss of productivity, and it affects compliance directly in patients with DME. And of course, this will ultimately have an impact on the visual acuity. Real world evidence also shows poor visual outcomes with less number of injections. So in agents such as aflibercept, ranibizumab, if you do not keep persisting with injections, they will have suboptimal outcomes. If you look at our perspective as a physician, we of course, all of us like to have agents which can be long lasting. So in the PAT surveys, the ASRS keeps sending these surveys almost every year, and we see that year after year, we all ask for agents which are long lasting and have longer duration of action. So this is again the same thing which shows that you would like to have agents that have greater improvement in visual acuity, reduction in macular thicknesses, and improvement in diabetic retinopathy severity. From the healthcare system, of course, the treatment burden, monitoring burden, the cost, and the utilization of OCT, and now you have OCT angiography, this has a significant impact on the healthcare system in terms of the hospital visit days, the outpatient days, the eye care related visit days, and the medication visits. So all of this just leads to limiting the capacity for treatment in the working age population. We have young patients now having diabetic retinopathy, especially in the Middle East. We have a lot of patients who are in their 30s presenting with very high HbA1cs and detecting with new onset diabetic retinopathy rather very early, already leading to a loss of work productivity. So these not only lead to clinical challenges but also administrative and cost challenges, especially in countries such as ours. Now, I'll just like to tell you about the multifactorial nature of DME and the key points and summaries from the clinical trials that have been addressed by brolucizumab. We need agents that satisfy these unmet needs, provide maximum and sustained visual gains, and require fewer number of injections, benefiting all the patients, physicians, and the healthcare system. How does brolucizumab address this gap? Now, the KITE and CRESTAL study were really the phase 3 landmark studies that led to the approval of brolucizumab in diabetic macular edema, and I was fortunate to be a part of the KITE, which had the Indian arm. So you see, both the KITE and CRESTAL taken together have a very good international representation of patients, and these were compared with aflibercept that was used as per the label. Now, if you look at the CRESTAL, you have three arms that have been highlighted: the 3 mg brolucizumab, 6 mg, and aflibercept 2 mg. And the primary objective was met for brolucizumab 6 mg, and the mean change in the visual acuity was comparable to aflibercept with fewer number of injections with brolucizumab 6 mg. So you have a significant number of patients there, and you see also the change in the visual acuity correlates with the macular thickness decrease, and you see robust improvement have been achieved with brolucizumab in both the studies. And you see minus 159 or minus 180 micron difference, at the average of week 52, and so this meets the secondary endpoint for these studies. So you see more number of patients with brolucizumab achieved a very good anatomical outcome with a decrease in macular thickness less than 280 microns at week 52 despite lower number of injections. So you see you have almost 7 injections versus 9 and 11 versus 15 injections at week 52 and week 100 respectively, and this is also seen in the KITE study. So this is a big difference in week 52 and week 100, especially the first 2 years when the patient has an active disease. And fewer patients have persistent IRF and SRF at week 52 despite lower number of injections. So there is no doubt from clinical trials and from our real world experience that the anatomical drying effect of brolucizumab is far superior than some of the other agents that are available to us. So you see observed treatment status at week 100 in both KITE and CRESTAL, you have about 60% patients on Q8 weekly treatments, in the kite and crestal taken together. And if you look at patients who are on more than Q12 weekly, that amounts to about 47%. So this is close to saying that almost half of your patients can be maintained every 3 monthly injections, which is really something that we all look forward. And this translates to about 4 or 5 injections every year if the disease remains stable. This is a very much a desirable change from the other agents that we talk about monthly injections. So in both the studies, as you see the kite and crestal, the number of active injections in the year 1 are less than aflibercept arm, and this carries on in the year 2. And so if you look at the total number of injections, you are talking about a median of 11 injections of brolucizumab versus 15 injections of aflibercept. You know what this means is that you are looking at an agent that can potentially increase the treatment interval without compromising the visual acuity or anatomical. In fact, it's giving a better anatomical outcomes. And this is something that we all desire. Sir mentioned about the safety profile, and the clinical trials in DME did not really bring out safety signals of brolucizumab. And to my knowledge, I have injected several patients. We have used in Cleveland Clinic here, hundreds of patients have been injected with brolucizumab. We don't have any in-house patient with intraocular inflammation in the context of diabetic macular edema. And therefore, this becomes really important for us. The safety profile has been consistent with no new safety signal. And I'm talking to you this specifically about diabetic macular edema. We are using it as a first line or first/second line treatment for DME because of its excellent safety profile, at least in our population. So in the real world, I'll show you some case examples. This is a patient who is treatment naive, diabetic macular edema. And when I look at the OCT, I just not only look at the OCT, but sometimes looking at the infrared also gives you a very good idea about the leakage around the macula. And you see here that not only in the center there is paracentral edema, and this patient definitely needs an injection, was treated with brolucizumab. And you see the patient had a very good response sustained with brolucizumab, and therefore this can be a very effective first line agent. As I said, usually I start it and I try to give it initially monthly, 4 to 6 weeks initially, and then I use treat 10 or a mixed sort of a protocol where I call the patient every 6 weeks initially, and then from the 3rd to 4th injection, I think I can extend the treatment intervals. This is another patient where you have hard exudates in the center, and this is what concerns us because a lot of times traditionally when you look at treatment with anti-VEGF, our fear is that these hard exudates can become subfoveal and they can cause visual acuity obscuration. This patient received aflibercept, and if you look at this hard exudates, they have kind of migrated, changed. There is cystic edema still, and this patient was continued on aflibercept, and now if you look at the hard exudates, this becomes very concerning. In the past, we used to depend on probably corticosteroids as a better alternative to anti-VEGF to absorb these hard exudates. So in this particular patient, we actually did not do corticosteroids. We did brolucizumab, and you see the anatomical response. The hard exudates just disappear. And I think this is something which should be looked at in more details. And these kind of responses, especially resolution of hard exudates, fibrosis, they may be quite better with agents such as brolucizumab. This is another patient of treatment naive DME. I'm talking about the left eye. You see the initial visit, the patient received 1 brolucizumab. 6 weeks after the first dose, the patient definitely had to receive another injection. The OCT itself is a non-favorable OCT. So when I look at the OCT, I tell the patient this is a non-favorable OCT. You will need multiple injections. The second visit, that you see the number of hard exudates have again decreased. After the second dose, 6 weeks later, the visual acuity has improved to 20/80, and the patient does receive the third injection. Now this is 7th week after the third dose. You see the anatomical response is much superior, but you have to persist, and this patient has received the 4th injection. 7 weeks later, again, you go ahead with the 5th injection. Now, you see here, I've already started to extend, and this is 13 weeks after the 5th dose. So this is typically what you will encounter in practice, that after 4 or 5 injections, you will realize that now you can extend. And you see the visual acuity is so much better. It's 20/50 now compared to 21/25. And of course, we persist. Some of these patients may require for a long term, 12 weeks. This is 12 weeks after the 6th dose, and then 13 weeks after the 7th dose. So you see, this is how you can kind of extend the treatment interval, beginning 3rd to 4th, sometimes earlier, sometimes later, and you may extend it beyond 12 weeks or even more. This is another example of a patient with age-related macular degeneration here. You see there is leakage and there is neovascularization on both fluorescein and ICG. This patient was a long-standing case. They received multiple aflibercept injections in 2016 without any response. Continued on aflibercept in 2017, hardly any response. And you see the OCT is so bad. There is so much of fluid, the bridges are broken of the intraretinal tissue. And this is actually a picture after PDT. So, as in 2017 or 18, we did not have so many options. And so PDT was tried for this patient, but you look at the anatomical response is actually much worse. In 2021, ranibizumab was tried, aflibercept was tried, nothing worked. This patient was 2200. And so 2200, I think, is a visual acuity where you can still maybe persist with injections if the patient feels comfortable or some mild improvement. This patient received brolucizumab, and you see this is the impact of the anatomical response. It's not the anatomical response alone. He improved from 2200 to 2125. And so this gives us, the confidence to continue the patient on brolucizumab. So the key obstacles really in DME are to reduce treatment burden. We want to maintain a sustained response. And brolucizumab does give you the option of sustained response with better anatomical outcomes, longer treatment-free intervals, and in DME it has a very well-tolerated safety profile with no new safety signals. These are the statements of Pagenex, and I thank you for your attention, and I'm happy to take any questions. Thank you.
Thank you, Anirudh, for an excellent insight into usage of brolucizumab. My question again will remain, how do you get rid of this fear? Because I am reasonably convinced that, you showed excellent slide, patient resistant to aflibercept, even PDT, and multiple injections, but miraculous response on brolucizumab injection. You see, in last session also, we were shouting about the drying effect of brolucizumab, but majority of the people still do not want to use it because of the fear. So I am unable to, convince people because they go by all the American data and kite crystal studies and the label which Novartis has inserted into that pack, and maybe some personal experiences also. So they say that, till the time it is resistant to one drug, two drugs, three drugs, then they may try. And then we have Mallika Goel with us. She is a fond user only of aflibercept, and hard exudates. She aim is to convince each other basically. Aim is to either you get convinced or you convince us. Because the slide which you showed, last slide, was very, very convincing. And you said hard exudate may be one of the biomarker for you to use brolucizumab. So Mallika says hard exudates, drug of choice still is aflibercept, no steroid also. So I'll have Mallika's reaction because she has already got up.
No, I think Dr. Agarwal's point is well taken. When you have hard exudates, you need a very effective agent. If you are not using steroid, then it should be a newer potent anti-VEGF. So since aflibercept was the drug available, and it is safe. I agree that brolucizumab is very effective, and so that will be a very good option for
So have you
hard
tried
exudates.
brolucizumab in such patients?
No, I have not tried, and because of the risk of inflammation, I do not want to take. If there is aflibercept which is working as well, or maybe little less in some cases, but it's better than taking a risk. I would prefer not to take a risk and then.
No, but the point I want to say is that, Anirudh, you said that there is less inflammation in DME patients. How can you explain that vis-a-vis AMD?
So I'll just give a brief perspective on this. Inflammation in brolucizumab is very different from AMD eyes and DME eyes. The clinical trial data on Kite and Crestel actually did not show safety signals in DME. I don't have a real working hypothesis, but probably there has been a Japanese study on risk factors for inflammation after Brolucizumab. And the risk factors really include high age, more than 80 years, or previous inflammation to other agents, and AMD eyes. So I think in AMD it's a different story altogether. In DME I'm not really worried about inflammation. And I tend to use Brolucizumab quite often. And so in my practice, the fear factor which sir said is difficult to get rid of it completely. But because you build a confidence on experience. So once you start using the agent and you see the good response, I don't typically use any corticosteroid agents. I don't do any wide field fluorescein angiography before Brolucizumab. So in DME eyes, I'm actually very confident of using the agent. I may be calling the patient initially early for a follow-up to look for anterior chamber cells, but even that over a period of time I have stopped doing it. So I think it just takes, you have to take the initial leap of faith, and then once you develop a confidence in the molecule, it will be easier to proceed with that.
So DME, you see, there is a inflammatory theory also. Whenever we, talk of steroids, we always, there was a BJO editorial that is DME an inflammatory disease, and a lot of studies have been done which show various cytokines levels elevated and good response to steroid also. And here you make a very confident and very loud statement that you do not use steroids and instead prefer anti-VEGFs, and that too specifically Brolucizumab.
I think, sir, with the newer agents coming, the maximum hit has been taken by corticosteroid implants.
Yeah.
Because all of us fear cataracts, glaucoma, steroid responsiveness. And so if you have an agent which is giving you a response which lasts for 3 to 4 months, then why not to use that agent instead of an implant? So I think that is what has happened really. We are using Eylea, like ma'am said, as first line, but I think these newer agents have also taken up the place.
100% I agree with you, because these newer agents, because of the durability, because of less number of injections, because of better drying and sustained similar vision or comparable vision, does make sense that this new agents may become the first line of management, and maybe even ranibizumab may see its way out in next couple of years.
I think, Lalit, if I can add, I think that the concerns about inflammation have been vastly overstated. At least in Eastern India, I remember last time we had AIOS in Eastern India, Lalit was chairing some session, he said you're using too much Brolucizumab. We've used a lot of Brolucizumab. Anybody from the Disha group is here, they will put their hand up. The enormous number, I used as first line in DME. I have not personally, myself have treated more than 300-400 patients with Brolucizumab, not seen one case of IOI. I've seen 2 cases of IOI referred by somebody else, but when they come in from somebody else, you're always worrying, is it the drug or is it the technique or is some betadine gone into the eye or something else happened? You don't know.
I agree.
But in my hands, not one IOI in a margin. So real life, it may be genetic difference between Caucasians
we should not talk about, because these doctors have been injecting other agents. If you say that betadine gone inside the eye or other cause of inflammation, that should not. But I agree with one aspect. I agree with one aspect. I agree with one aspect that in Indian eyes, inflammation is less. There's no doubt about
I've
it.
also seen 4 inflammations, serious inflammations after Eylea. Referred to me.
Anirudh,
So that
true.
question is valid. I'm sorry, but
No,
we
no.
were just speaking earlier that everybody is injecting right, left, center.
How many in the audience have used Brolucizumab? So I think 50% people have used Brolucizumab, but rest 50%, we have to convince use because of this wonderful molecule, not because this is a sponsored session, but primarily I still have data, so many patients, not one, where we bank upon a drying effect. Drying effect is actually too much, and I agree with Anirudh's statement once that these newer agents with promise of increased duration may make a dent in the steroid market.
Anirudh, one question. What do you think about which drug would be better for DME, Vabysmo versus Paganex?
Very difficult question to answer, sir. But what I do is I look at some biomarkers, let's say on the OCT. If it's a plain simple eye with a treatment naive, maybe macular edema without a unfavorable OCT, then maybe yes, faricimab could be a very good agent to start off with. But if I feel that the OCT, there is a lot of fluid, subretinal fluid, and there is a lot of capillary non-perfusion, in those eyes, I generally like a stronger agent like Brolucizumab. So this is how I typically do it. All of us have a different way, but sometimes it is random. And I'm being honest because I may not be able to have a strict criteria when I do Brolucizumab or faricimab or Eylea. It depends on so many factors taken together. But I encourage, I think in the audience, there are many who don't use. I encourage you to at least try it in patients of DME. Try to use it, see how you feel. And sometimes we are trigger happy, we feel there is inflammation. So I had one patient referred to me with AMD, injected Brolucizumab, and it was referred to me as occlusive vasculitis. And it was nothing but a subretinal hemorrhage, which is common in AMD eyes. So some of us may fear the unknown, and therefore you may feel that there is an inflammation or a vasculitis, but it may be sometimes maybe a vitreous hemorrhage or subretinal hemorrhage.
So what you are advocating is a stronger agent for a severe DME.
Yes, I think so. I think that has come into our minds, especially looking at the data from Kite and Crestel. Unfavorable OCT, probably I lean towards Brolucizumab.
No, but Anirudh, one more point which I loved about you is that, the older patients have more inflammation, so these diabetics are younger patients. So there's a less incidence of having anti-Brolucizumab antibodies in there because they are younger.
Yes.
And these older patients have a higher incidence of maybe getting those, anti-Brolucizumab antibodies. So that was really a great point which you brought out, that the younger patients who are diabetics will have a lesser incidence, which is reflected in the studies. Am I right?
In U-Retina last year, sir, if you look at the data, there was a poster presentation on faricimab related IOIs. And again, so IOIs can happen from any agents, from aflibercept, from ranibizumab, all of these are biologics. And these are all high risk in high elderly population, more than 80.
Anirudh, one question which is striking me is what about peri-cataract surgery period? Like a patient, suppose is having cataract, reasonably advanced cataract, plus has DME, and he has been maintained on some anti-VEGF agents. So what is your approach? Because you say you use Brolucizumab as first line in diabetic. So
Yes.
how do you approach?
For cataract surgery, even if the patient is maintained on anti-VEGF, I generally shift to steroid. I do steroid implant either at the time of cataract or 1 week prior. And once the cataract event is over, then maybe I can go back to anti-VEGF. But in those cases, I depend on steroids.
Okay, I think we will keep diving deep into this disease. Let's hear personal experience of Dr. Gopal Pillai with this Brolucizumab. Please be on the line so that we can have some discussion. Yeah.
Thank you very much, sir. As we know, fluid always plays a significant role in neovascular AMD and DME. And what we have to now know is how rapidly we are able to reduce the fluid and how long are we able to control the recurrence of fluid. So all the guidelines for retreatment decisions are based on presence or absence or occurrence of new fluid, and persistent fluid will definitely lead to lower visual gains, and CSFT fluctuations may be associated with poor vision gains in diabetic macular edema. So what we are looking at is for faster action and longer duration. So we know about the single chain antibody fragment and how this is a much more smaller fragment, and so what happens is that the molar concentration that this offers is like about 12 times higher than aflibercept. This is a much more smaller molecule. The clinical dose is 6 milligram what we have, and the relative number of molecules is like much higher than other anti-VEGF agents. like aflibercept, it's 1 as compared to 11.2, about 12 in the brolucizumab group. So brolucizumab has the smallest molecule, which means it can probably penetrate much more deeper in choroidal, choroids, etc., and designated especially for ophthalmic use and potentially addresses these unmet needs. And preclinical studies suggested that smaller molecular size of brolucizumab may facilitate better retinal penetration. So that is again another factor. High ocular concentrations are balanced by rapid systemic clearance. That is also very important. So if you're putting a higher dose of the drug and it crosses into the systemic circulation and causes more problems, then that becomes a non-starter. Whereas here, even though the eye concentration is very high, the rapid systemic clearance makes it much more safer in terms of systemic approaches. And each 6 milligram delivers a 12-fold higher molar dose than aflibercept of the same volume, so which has the potential to deliver durable efficacy. Brolucizumab binds with high affinity to the VEGF-A isoforms. So in Crystal and Kite, we can see that by 100 weeks, there are significant patients, there's a significant difference between aflibercept 2 milligram versus brolucizumab 6 milligrams. So by the percentage of patients with intraretinal fluid or subretinal fluid was about 41 versus 54, and percent of patients achieving a CSFT less than 280 was again 63 and 51, which makes it significantly different. So visual gains were comparable to aflibercept. In fact, that was a comparative study like that. In both studies, patients treated with brolucizumab received fewer injections, like 11 injections by 100 weeks, that's 2 years, as compared to 15 injections of aflibercept in 2 years. Overall safety profile was consistent with the 52 weeks data, so which means that brolucizumab as well as aflibercept in terms of diabetic macular edema, like Anirudh was telling, the intraocular inflammations were much lesser. Now the post hoc analysis of Crystal and Kite, the time to dry, so that was significant. So you can see the area under the curve also. So you can see that brolucizumab dries much more rapidly. By week 52, it was 37 against 32% in the Crystal, 40 against 31%, so about 10% difference. By week 100, it became 83 upon 70 or 80 upon 57, which means there was about 15% difference in the rapidity of drying. And time to achieve CSFT, that also you can see by week 32, 50 against 35, and by week 52, it's about 58 against 46. Much more rapidly the brolucizumab was able to dry. So time to sustained dryness, which means that now we are looking more towards duration. Can we have, with 2 consecutive visits without injections? So at least 3 months can we push without injections? That also brolucizumab against aflibercept, you could see that there was a huge difference, like 78% against 76%, 47 against 32, 50 against 34, about 12 to 15% difference time to sustain dryness, and also to achieve a CSFT of less than 280. So we all know fluid plays an important role. Brolucizumab offers a unique structure and higher molar concentration. Efficacy has been proven through the Crystal and Kite studies, and safety is also done. Comparative BCVA gain and numerically more fluid reduction, and fewer number of injections compared to aflibercept, faster and sustained drying. So this is one patient who had come to me with diabetic macular edema, who had both eyes injected ranibizumab biosimilar over a period of time, and then over a period of time he was lost to follow-up and came back like this. And on the right eye, you had this particular picture. You had a hard exudate which is abutting on the center of the fovea, which with brolucizumab completely dissolved. Whereas the other eye of the patient had significant edema like this. And you can see with each injection of brolucizumab how things are changing slowly, slowly, slowly. And then at this point of time, cataract had come, and that had to be removed. Now, this is another patient who had been treated on ranibizumab biosimilar again with no good response after 4 injections. And then you can see that this was the time when he was being treated with ranibizumab. And in fact, you can see that at some point of time, there was a little delay in treatment here, and that is why probably the edema went up here. And you can see that once we started treatment with brolucizumab, this was probably a patient who has, so for the first time, we reached complete resolution of fluid. And then the injections, you can see that slowly, it is improving, and at some point of time, that is completely reaching resolution. And the number of injections that you will require and the dryness and the rapidity of reduction is much easier and faster with brolucizumab. In my practice, I have used brolucizumab more extensively in wet AMD than in diabetic macular edema. There is a learning experience which is coming in, and with more and more confidence, I would be moving more and more into the diabetic macular edema. Thank you very much.
Thanks, Gopal, for this. I was expecting more cases. Actually, you showed only 2 patients, so we were wanting more real-world scenario because, as you rightly said, the purpose of all these CMEs is to learn from each other's presentation, and seeing cases gives a lot of confidence. So, because Anirudh said that if in contrast to AMD, DME is much more responsive and less chance of inflammation also. So maybe I think the next meeting you should present data of brolucizumab in DME also.
Yeah.
So I just have one query. Like the younger patients should have more inflammation. I haven't gone into the data, so I can't say. But we know from that younger patients should have, and that's how in the gene therapy for DME as well as AMD, they had to stop the treatment for DME because of the severe inflammation leading to phthisis. So I just wondering why it's different for brolucizumab.
Anirudh.
I can answer that. I think that is probably related to the cumulative effect. And so if the patient grows older, maybe that patient has been exposed to more biological agents in the body, and that's why that may be a cumulative response. And younger patients may not have that. So that could be one factor identified in that particular paper.
But younger patients generally are more reactive. No? More reactive means any injury, any wound, anywhere, the response is more or like keloid formation rather than an older patient. But I agree, older patients, it's more likely that they must have been exposed to all these agents more than the younger patients. So cause may not be, these are all theories which, we agree with each other.
I think one of the take-home messages from me, from the 2 talks from Aniruddha and Gopal, is that seeing that the hard exudates, you've shown these nice cases where the hard exudates are disappearing. Till now, I will change tomorrow. Till now, if I saw hard exudates there, I would give Ozurdex. And then with the losing heart, if there's a subfoveal hard exudate, then I'm almost thinking I've lost the game. I have to do something. I give the steroid. But maybe I'll go back and use the Pagenax now in those patients.
Yeah, and we haven't lost the game. Actually, I have been giving in subfoveal as well, and they do improve a lot. After a few injections, after a year, the vision is very different. They may have started with 4/60, and now you are ending up with 636 or 624. So it improves. Don't give up.
I could not go.
Sorry, if this happens after a year, because you see, if it's either it's a effect of the drug or it's the effect of disease modulation.
No, drug. The disease was always there for years. When you intervene, then you see the change. And you see the exudate going away.
Once we start treating a disease with injections, patients generally becomes afraid also, and he starts his control better compared with prior experience. So if 1 year or maybe more than that is being taken to have that effect, then if the drug effect has to come, because the pharmacokinetic data shows that the peak effect comes say in 8 weeks or whatever, then it should come early.
Yeah, it starts coming. I'm just talking of the final vision. But you start seeing the exudate disappearing and vision improving immediately in 2-3 months.
Gopal, I wanted to ask you, what I was looking at, I shifted a few of my patients on Ozurdex because they developed glaucoma, recalcitrant glaucoma, which was due to, last stage diabetic disease also. So can you extend to 3 months, because in those patients whom I switched from Ozurdex to Pagenax, I could manage to maintain them for 3 months with a single dose of Pagenax. Have you seen that in your chronic patients? Not treatment-naive patients, I'm saying.
Generally, we will move to Ozurdex when they are not responsive so well to the anti-VEGF. So the anti-VEGF, what I meant was the first group, in the sense ranibizumab or bevacizumab or aflibercept. So if that is not acting, then only we usually move to Ozurdex in diabetic macular edema. Or if you want to reduce the number of injections. Now Brolucizumab has come in as like 3 monthly or 4 monthly you can inject. So definitely it will be a good strategy, like Anirudh said, because we do not have to subject these patients to glaucoma or cataract. So that's a very good thing. Now second thing is, in a patient with Ozurdex, if I have a glaucoma, if you do a trabeculectomy, then you can continue the patient on Ozurdex for no problems.
Yeah, that's acceptable. So Anirudh, Gopal, first line and last slide also was drying. And this fluid theory, propagated by, a lot of people for last year or maybe two. So they say if some fluid is tolerable, SRF is tolerable, even sometimes they will go to the extent of saying that this may be associated with better visual acuity also. So I fail to understand that how come, fluid is tolerable. I personally feel that fluid not getting, it's a defeat of the drug rather than saying that fluid is tolerable.
You're right, sir. In DME especially, you cannot tolerate fluid in DME. Absolutely no, not even intraretinal or subretinal. In the context of AMD, in the fluid study, they did say that the fluid in the subretinal space may be rather protective. But not all of us follow that because there is no real evidence to say that subretinal or sub-RP fluid is actually protective. So in general, I think we all give up, and because you give up, you try to latch on to something, and so you say that this might be actually protective. If the agent is probably ineffective, that's when you can kind of give up on the treatment and just say, it is protective.
Absolutely.
No, I would like to say, sir, that in the real world, it is completely different from the clinical trial scenario because,
yes,
initially, when a treatment-naive diabetic macular edema comes to us, we will definitely try to keep him fluid-free. Yeah. But after 6 months, 9 months, if the number of injections are mounting, then he and we will have a discussion together to keep the little bit of edema with lesser number of injections. Maybe in 1 year his vision may drop 1 line, but that is okay considering, the discussion will come out to say that he is okay with 4 injections instead of 8 injections.
So Gopal, my reaction to this is exhaustion by patient as well as the doctor.
Yeah. So,
this
this
exhaustion.
finance comes in and science takes a back seat, is what I've seen.
Correct.
Let's be frank.
Correct.
Finance takes the first seat after patient is exhausted, and his funds basically is what I feel. That's what it decides.
Logistics and finances, I think. So
And about the OCT biomarkers, you said, if there are, or color photograph biomarkers, if there are a lot of hard exudates, today your drug of choice will be Anirudh?
So if it's a non-favorable OCT, hard exudates, the sketic changes, that even Dr. Gopal sir, he showed OCT with a lot of sketic changes, I would go for Brolucizumab.
First line.
And because I would like to give the benefit initially, rather than give Eylea or something else. Maybe they work.
So a lot of people say that in diabetics, if you delay treatment by a couple of months, heavens are not going to fall, and you control the metabolic status first, and then. So how do you react? Suppose a patient of hard exudates, lot of hard exudates, and he has poor metabolic control. You still go ahead and do Brolucizumab.
This is a little. I'll answer it in 2 ways. So if there are lots of hard exudates, of course I will do fluorescein. I might even do laser because I still do focal laser, sometimes micropulse laser. So it just depends on the amount of fluid. If the fluid is not much, maybe I'll do laser with systemic control, delay injections. But if there is fluid to begin with, center involving, then there is no point of delaying the injections. You have to inject. So this is how I usually do it.
Anirudh, I loved yours. Yeah, sorry.
I think the point Anirudh is making, the point I also wanted to make, is that yes, people talk about waiting for metabolic control. If the patient has good vision, if the patient comes to you with 6'9", yes, please wait for metabolic control. If the patient already is 6'12", 6'18", then both go hand in hand. I will give them the injection and try and get the physician to do the metabolic.
A word of caution there, because some of these patients, when you send for metabolic control, they come back after 3 months with loss of metabolic control and loss of vision also.
Yeah, I agree. Why deny treatment in this, exciting times when we have agents to, reduce it?
I would want to answer
metabolic control can go hand in hand parallel.
No, one more thing, sir. The diabetic doctors, the endocrinologists, they have changed their management of systemic control. Now we have newer agents, long-lasting insulins, we have weight loss agents, we have bariatric surgeries. In the context of all of this, I think it becomes very difficult to depend on factors like HbA1c, to depend on fasting sugar, for example, because these are so variable. In a patient who's had bariatric surgery, now there is evidence to say that HbA1c values have to be considered separately. So with so much going on the endocrinology side, I don't think we can solely depend on systemic control for 3 months with a center involving edema. It's very difficult.
I want to bring in another aspect, sir.
I agree with laser part only when it is laserable. If it is center involving DME,
then no point.
Yeah.
Sir,
Yes,
may I bring in another aspect? Now, with Brolucizumab telling that the molar concentration is like 11 times higher than the other drugs, and now Aflibercept bringing in the 8 milligram, which makes the molar concentration higher, is it that the higher molar concentration of these drugs are actually making it more efficacious than the primary generation of anti-VEGFs and increasing the duration? Now, for example, now if we are having higher concentration of ranibizumab, for example, would it make a difference?
You're asking me, sir? Should I answer that?
Yeah.
No, yeah.
So I think what AIOC has done is something very simple. They have basically increased molar concentration to increase durability. And so that is slightly different from the molecular structure of Brolucizumab itself. In Brolucizumab, the difference is in the structure itself, which is giving it probably higher efficacy, higher durability, less clearance. So I think there is some basic fundamental difference between the two. I'm not sure if that will work for ranibizumab by just increasing the molar concentration, because it depends on the affinity of the binding. So there are lots of things involved, and of course the safety and other parameters. I think ranibizumab has already hit the hilt. It is the maximum possible. So far we're waiting for AIOC. Maybe, let's see how it goes.
Lalit, can I bring in another aspect? We keep coming back to economics in the previous session and in this session. And the one thing I like about Pagenax, I'll go out on a limb, is that it does not have a patient support program. Why? Patient support programs are good because they reduce the cost. But one, they distort clinical practice. If I've given 3 Eylea and I want to change, the patient will say, "Sir, fourth to free milna tha na." So and I'm seeing no effect. I say, why am I giving this fourth?
So your point is that there should be no PSPs.
That is one point, sir. That is the first point. The second point is the PSPs are administered by a third party, not by Novartis, not by Roche, not by Bayer. Some third party has the data of my patients. I'm strictly against that. I don't like that. They're even asking for the patient's Aadhaar cards. And data is strength today. Somebody who has a database of all my patients can do whatever with it.
So Somdar is very emotional about secrecy of data, but we are talking pure science as this moment.
You give me a drug at an average lower price is much better to me than give me 1 + 1 + 2 + 1 + 5 + 7, whatever.
So Novartis people, we will request that instead of giving us PSP, you reduce the price slightly so as to be competitive. So that is better than. Anirudh, do you have any patient or any data or observation or comment regarding the patients who are DME on Ozurdex and you have shifted to Brolucizumab?
Yes, I have patients on other agents, including steroids, shifted on Brolucizumab, simply because after 2 or 3 Ozurdex, I myself become slightly uncomfortable, especially in phakic patients, how long to pursue with steroids. So I have shifted them, and in fact successfully. Another aspect, I think, vitrectomized eyes. In vitrectomized eyes, previously I used to use only Ozurdex, but I think Brolucizumab works very long. It lasts long. Third thing, in patients with systemic diseases like strokes or cardiovascular events, I think with ranibizumab and aflibercept, there was, although the concern has been junked by systematic reviews, but faricimab, even Brolucizumab, these agents could be tried.
So you mean to say that patient who has a recent history of MI is 0.3 milligram Razumab or ranibizumab safer or Brolucizumab is safer? Patient who has a recent MI.
Actually, sir, the data shows that both can be used, but the systematic reviews, meta-analysis say that both can be used. But It's personal preference. I use either Brolucizumab or Faricimab.
Yes,
One
Malika?
point, a point I'm saying, trying to make is we don't have the port delivery system with
Yeah,
ranibizumab.
PDS, huh?
But actually, if we had that, that is extending the intervals to 10 months easily. So, and now it has been revamped. There was some defect in the device.
Yeah, there
So
was, you see, they went out of this thing
now it is
for-
again back.
Yeah.
And now the patients are very happy with the 10-month intervals that they are getting. So we don't have access to that. But ranibizumab can also be extended. There was I think Dr. Gopal had brought up the point, whether it's just molar concentration which is making the difference. So we can, in fact, even with ranibizumab, extend the interval, but we don't have the PDS.
I'll just give one perspective on PDS. The PDS is running into a couple of more issues, which is it is converting a medical case into a surgical case because you need to do vitrectomy there to implant that particular device. And so we are running into insurance issues because you have to open the pack, you have to take the patient into OR, do a vitrectomy, implant the device itself. And then this, although it can be refilled in the clinic, but implanting it has to be done in the OR. So I think that is something that the company is still struggling with. They would like all the procedures to be video recorded. So like Dr. Sir was saying about the patient confidentiality and, so I think these are some issues that the PDS still has to overcome.
So how much vitrectomy is advocated? Because PDS, you see, apart from that incisional issues and vitrectomy issues,
Yes.
so 8 months advantage vis-a-vis,
Even 10 months, 12
it has to be, loading
Yes.
can be done, refill can be done in OPD, but generally
Yes.
first procedure is a surgical case then.
Yes, so it has. So the company says the vitreoretinal surgeon has to do the implant, and they say that it has to be done keeping all the vitrectomy instruments available in case a full vitrectomy is required. They say that localized vitrectomy has to be done in that particular area.
Okay, any other comment or question by anyone? So I think we can wind up this session by making a couple of comments which should, remove those myths people have. Somnath, you were talking something about economics. If you have increased durability, I have prepared a couple of slides about economics, which I was talking in the last session. I don't know how many people were there, but these longer agents, because of the increased duration, ultimately, if you calculate yearly cost, they come out to be cheaper than even ranibizumab or even biosimilars or even Eylea.
Absolutely, sir. I have personally been using Brolucizumab for DME before it was licensed for DME. So it was licensed for AMD, but not for DME at that
So
stage.
for you,
and I have a lot of patients who are on 4-monthly treatment now. Not all, maybe about 1/3 or something. Not all. Some are on 3-monthly, some are on more often. But a lot of patients can be even managed on 4-monthly. So for them, it is a very cost-effective drug. For them, it is cheaper than biosimilar, actually.
So last point is about the visual gain. You see, we talked about fewer injections with Brolucizumab. We talked about more drying. Gopal said faster drying without any compromise of visual acuity. What about visual is similar to aflibercept, or do we have, because does more drying translate into better visual acuity or not?
It's comparable, sir. As per the clinical trial evidence, they say it's comparable to aflibercept, and this
Real
is at
world-
350
real
and
world?
800. Comparable. There is no study which says that any agent is superior to the other in terms of visual acuity.
So I think if
The trial, there's no study like Aniruddha says, but if you look at the graphs, or the Eylea graphs have the sawtooth thing, which we've always seen. The Brolucizumab graphs do not have the sawtooth thing.
Yeah.
To me, I can't prove it, but that is a better thing. There's something going up and down is better than something, is not as good as something which remains stable.
100%, I think, Anirudh, I agree with what Somda is saying, is that
Yes.
you see any retina where, we are talking fluid amongst the photoreceptors. So you have some fluid coming, then going, some coming, some then going.
That's not
That may have a detrimental effect on the long-term function. So even though statistical data by studies or even real world do not show a greater benefit, but more drying, a sustained drying will definitely, I think, have a better long-term prognosis.
Absolutely agree, sir.
So I think with this, if all of you agree, we can conclude this session by saying that all the myths about surrounding the use of Brolucizumab need revisit, And the eye opener from your talk, Anirudh, was that patients who have hard exudates, they may be preferred treated with Brolucizumab, with the advantage of fewer injections, more drying, faster drying, without compromise of visual acuity. If there are any further questions, we would love to take. So thanks, Anirudh, for joining us, and
Thank you.
maybe we'll
Thank
meet physically also sometimes. Thanks a lot.
Thank you.
And
Thank
thanks
you,
all the
everyone.
panel and Malika especially for sitting in this session.
Thank you.
Thank you.